And last time, what was discussed was what type of different systemic mycoses can actually affect human beings, like the host, right? And we are talking about few species, and one of the species we have started was mycosis dermatitis. And what are the different forms? So if we remember, uh, we understood that are the three different forms. One we call as an acute pulmonary. Second one we call as an chronic pulmonary, and the third one we called it as an disseminated blastomycosis. And then we actually described that how does this mycosis actually causes different type of disease, plus how can we diagnose it, what are their culture characteristics, and with that we came across what can be the probable laboratory diagnosis for it. So we started with just understanding the basics of culture, that as soon as we want to stain it, what can be the particular stain we should use. So mostly we keep it under an alkaline condition because it is usually an acidic fungus. If you remember, most of the fungus are usually acidic in nature. Why acidic in nature is because you will always see that majority of fungus grows in a media whose culture conditions are acidic. So near about let us say 4.5 to 5. And if we want to denature or we want to stain anything, what we need to do is we need to keep it under an alkaline condition. And that's, if we keep it in alkaline condition, the spores will not spread to the examiner who is going to examine the spores. So that's why KOH solution has been used. And using this particular solution, it was further found that yes, the general morphology of this is, it looks like yeast, but sometimes it remains under a particular hyphal form or mycelial form. So that's why it occurs like a thick walled globose structure. And each particular blastoconidium, which is at the bottom, is attached to parent cell. So this we actually discuss what are the colonial epigens in a mycelial form as well as in yeast form. This was the last slide which we were talking about, that if we are talking with respect to blastomyces, how does it appears in yeast form also and in fungal form also. So if you see it, you can see these are exactly resembling the yeast form, where the structure would be similar to this, where it appears to be very round, circular. So mostly a broad base budding yeast. With respect to mold, you can say it is a hyphal fragment or mycelial fragment, and this mycelial fragment is attached to a broad portion of mycelia or hyphae. So that's how it works with respect to yeast form and with respect to a mycelial or an aerial hyphal form, right? Then we come across that yes, if we are able to perform microscopy test, culture test, that is great, like, because we are able to understand what can be the morphology, how it can propagate, how it transfer. But thing is that we cannot wait for any culture to grow and then observe the culture, right? So what we need to do is we need to understand about what can be the probable serology test, like instant test, just like an immunology, where we can find some of the antigenic properties on the surface, and if we are able to find some of the antigenic properties on the surface, then we will be able to easily identify it, and then we can probably start the treatment of it. So for that, the immunodiffusion test has been specifically designed. Now in this test, uh, the most important thing to understand is what are the specific antibodies should be there against the yeast phase antigen, that we are talking about the specific antigen. Then what can be the probably an yeast phase antigen would be? So if we are working on yeast phase antigens and specific antibodies, we need to work on specific therapy, right? And for specific therapy, what is the most important is we need to find what is the exact site of the antigen binding to the antibody. Uh, So if we are talking with respect to antigen binding to the antibody, the most important would be the K antigen, which is mostly present on a dermatitis, blastomyces dermatitis species. And that's why, because it is highly conserved and it has been well recognized that it is one of the important factor for the virulence. So that's why if we are able to have a particular antibodies against such antigens which we recognize as an K antigen, then it would be best to understand that apart from a microscopy test, immunodiffusion test can also work wonderfully for identification of specific yeast culture. Then apart from serology or immunodiffusion test, there is complement fixation test. Now complement fixation works with a combination of specific titers. Yes, Anson. So antigen K, like, so what was immunodiffusion means? Over here, we bind or we target specific antigens against a specific antibody, right? You might have done in your practicals also diffusion. Now, usually how it works? Usually, antibody binds with a very specific site of antigen. But because blastomyces dermatitis is the species which changes its characters, right? It converts into a mold as well as it remains in yeast form also. So in both the way, if it is a mold culture, then also we should find a specific site with which if we can tag the antibody, we can find out the test is positive or negative. Or else if it remains in an yeast form, then also we should be able to tag it with a specific antibody so that we are able to find out, yes, it is giving positive or not. Now, whenever this blastomyces dermatitis is there in an yeast form, it has a specific recognition antigen which we called as an K antigen, right? Now, whenever this is specific, whenever it is in yeast form only. Now, this K form antigen will always bind to an antibody and give us positive result. So whatever the antibodies are there, if has a specific site against a specific antigenic site, and what is that antigenic site? That antigenic site is what we call as an K antigen site, right? And that's why this works very well whenever the particular culture is there in an yeast form only. Okay, am I clear, Hansel, or should I repeat it? Serological test, you are not able to understand. Serological test, what brings about the antigen K? Now, the name has been given only, otherwise it is just like antigen antibody site. And serology test, because we works with a specific blood components, blood components like serum, plasma, that's why it includes an serological test, right? So why antigen K is important? Because antigen K is a specific site which is going to bind with the antibody and gives us a specific result. There are many sites on the antigen which can bind with the antibody. Now, if antigen K site, there are different sites on the particular antigen. If that particular site binds with the particular antibody, then you get positive, otherwise you will get negative. So that's why it becomes a very specific, right? Okay, fine. Then apart from what we talk about serology, in serology test also, there is something which we called as a complement fixation test. Now, what is complement fixation test is whenever you have a specific cross reactions, right? Now, due to these cross reactions, you need to work in specific titers. So, if there is a binding with any specific antibody, because it is a not direct binding, we need to identify how much is the particular ratio through which it is an binding. So binding over here in immunological terms, we call it as an fixation, and that's why the test is called as a complement fixation test. Now antigen, we know it is a specific antigen which is representing yeast. So titers over here would be 1:8 to 1:16. Now, if your titers comes between this particular range, 1:8 to 1:16, then it is suggesting that there is an yeast infection over there, right? And if the titer exceeds to 1:16 or 1:32 to 1 or greater, then the infection is very well established over there. So over here, two titers are suggesting. One is what we call as an active infection, and second one we called it as an indicative of particularly chronic infection. So this is how we identify complement fixation test. But over here, one thing to note down would be also that usually cross reaction happens. Like whenever the patient has been infected with condidiomycosis also, apart from blastomycosis, and histoplasmosis also, apart from blastomyces, then that also in that conditions also, it might happen your titer comes low, but due to the symptoms and due to the particular antigen binding properties, further it can be confirmed, yes, that the person or patient has been infected with particularly specific blastomyces. But the problem would be here, because it is a combination of two or more than two particular species, we are not unable to identify that the patient is infected with which particular species, right? Because it might happen that because of coccidiomycosis or histoplasmosis, infection is much more prevalent. So we cannot say it is just an infection of blastomycosis only. It can be like coccidiomycosis or histoplasmosis. So this is somewhat whenever there are some conditions where the patient has been infected with two or three different particular species of fungus, right? Then there is also a skin test apart from what we call as a complement fixation or immunodiffusion test. Now, what can be the skin test would be? The skin test would be that there is a specific antibiotic, what we call as a blastomycin, has a specific diagnostic value, right? It gives us a specific reaction against the skin. But the problem would be again with respect to a cross reactivity. If there is another species also which might be present as such as a normal flora, we will not able to understand, yes, that this is the only particular species which is having a specific infection site or not. And that's why skin test has been eradicated. It has been not been used for identification of fungi, uh, right? And instead of that, complement fixation, immunodiffusion has been used. Okay. Then now, because we understood about the blastomycosis dermatitis species and the cause, what can be the particular morphological features of the species, it would be better we understand the difference between blastomyces and coccidiomycosis, right? And the other or synonyms of coccidiomycosis would be, it can be also called as an in a layman language, desert fever, valley fever, Saint Joaquin fever, right? Now, what is the causative agent of coccidioidomycosis? It is Imitis species, and because it has been found mostly in a geographical distribution related to some valleys nearby, it is also known as an valley fever or San Joaquin fever or desert fever. So usually it is associated with a geographical distribution, and mostly the species Imititis, right? Imititis is usually been observed or mostly been cultured near the valleys. So whatever the disease which has been caused, mostly the cases has been reported nearby that. That's why it has been given a common name like this, a valley fever. It has been mostly been frequently associated with an California valley and a specific region which we call as in San Joaquin. So that's why it has gained a common name which is called as an valley fever or San Joaquin fever. Now, what is the mode of infection and how the infection is actually spreading in the body is, now as soon as the spores attach itself into the body, it enters into an host tissues, right? Now, once it enters into an host tissues, what we need to understand is it does not take or utilize their own energy. Instead of that, it utilizes the host tissues, it utilizes everything which is associated with the host. And what it do is basically it has an it forms a small endospores. Now, as soon as we think of endospore, we think like a small particular spore which will be unique and which would be alone or isolated. So over here, it would be in small endospores, but it is usually found in the bunch. And within the endospores, even there is an found and presence of an sperules, which just like a mature spores. Normally, how do we identify that? If we see aspergillus, during first 2 or 3 days, it has an white color. Then after 2 or 3 days, it becomes black. So now what the blackness indicates is the maturation in the particularly fungal cultures, and the spores has gradually become matured. Right. So that's how we called it as a maturation, or the spores has become mature because it has gained the pigmentation. So over here, as soon as we are talking about the endospores, what happens? The mature sperules are being found. So these mature sperules is basically a main causative agent for the infection. Now, as soon as these spirules are formed or maturation stage has been reached, there is a rupture from the cell or outer coating of the spores. Now, as soon as the rupture is there, the endospores are released, it becomes enlarged, and again it will start the cycle of reproduction. So this is how actually overall and reproduction cycle goes, right? Now, the agent has two forms over here. One is called as a white fluffy mold on most of the culture media, but as a non-budding spherical form in an hot tissue or under an spatial conditions. This particular tissues remains intact, and under and whenever it gets in favorable conditions, it's directly liberated in the particular host. So one we called as a non-budding, and second one under an specific conditions we understand it can be in budding also. Now, if we talk about its epidemiology part, the epidemiology can be its geographic distribution. Coccidiomycosis is mostly endemic in Central America, South America, and because it requires in specific unique conditions usually associated with normal valleys, so that's why the dissemination is mostly in arid region or semi-arid regions, and mostly these two, like arid and semi-arid region or portions, is mostly found in Central, South, or like Mexico. That's why it is mostly endemic in that particular region. But the thing is, because it survives and it is spreading through spores, right? Basically, it is an sporulating or spreading through spores. So that's why it hasn't travel, or it has a case history of travel, that it usually it has been found in different parts of the world. And the only reason is it might have happened that one of the carrier has flown, or through particular carrier it has carried through and travel, right? What one can be the further source of infection? Usually, as we know, mostly it is soil only. At the starting of the particular session of systemic mycosis, we talked about that what can be the probable source of infections, and mostly over here the source of infection is soil only, right? So most of the historical and most of the case study has been done, and it was found that most of the patients has some or has connection to an soil exposure, right? Either through an particular air from an contaminated soil, or else through an windborne arthrospores like from dust. So there are many histories which has been associated with particular source of infection. Now, what can be the pathogenesis of it? Usually, the usual course of primary, mostly like pneumonia has been done, and if pneumonia is been healed, right, there is and specific characteristics that the pneumonia has been associated with coccidiomyces or specific immediate strain. Now, what can be the specific characteristics is wherever the pneumonia is happening, right, it has been usually detected by radiographs, that we go for a radiography and then we find out actually pneumonia. Now, what we nowadays also call as a CT scan or like that, right? Now, whenever it get heals, because as soon as the streptococcus or staphylo infection is pneumonia infection is gone or excreted out of the body, if you find a small coin-like lesions near your lungs, then the infection is actually been caused by imitate species. Yes, it can be the combination of and particular pneumono or pneumococci strain, but usually as soon as you found that it is having a small, just like a round or coin, 2 rupees coin, right? Nowadays even 1 rupee coin comes very small size. it is just for India only. Otherwise, you travel, you find coin size much more. So if you find a very small coin size lesion, you will always recognize, yes, this can be the probable reason for spreading of or having a pneumonia in it. Now, what would be the less common? Less common would be whenever you observe the tissues which has been infected with pneumonia. Usually we are correlating with pneumonia because pneumonia has been studied much more compared to other diseases, and it has affected the patients much more. So whenever there is a single thin cell cavity happens, you always observed that there is a cavity near the tissues. Further, it has been followed by chronic sequela, right, in the areas of the consolidation, like there is a chronic sequela is there. So that's how we usually find it, yes, that the particular patient has been infected with imitis strain. If still it exists to particular higher version of pneumonia, the higher version can be with respect to granulomatous disease, but overall it occurs very less. So the chances are less than 1% of the population has been affected with such type of symptoms. Okay, so we hardly know about it, that what type of symptoms or especially immunosuppressant disease this can be there, right? Now, if we talk about this specific things, then much more cavitations may occur. And further, if we talked about the pathogenesis, right, the usual pathogenesis, the infection may disseminate to different parts of body, like it can spread through in different part of the body, which can include bones, central nervous systems, and further mostly it infects mostly the GI tract, due to, even though it is high acidic conditions, GI tract is almost resistant to this particular species, and that's why mostly the chances are that it is going to infect mostly our particularly bones, it is going to infect respiratory tract, central nervous system, like that. Okay. Yes, Devi, any questions? Okay, by mistake, I think so. So I hope, anyway, we are not commenting on it. So mostly, yes, GI tract is remarkably resistant to that particular infection. However, the most common forms of this disease can be just like a flu. So that's why we call it as an influenza. And good thing about this disease, or best thing, is 60% of the cases remain asymptomatic. It remains to a specific person and it remains asymptomatic. Yes, I understand. Thank you. Great. So initial symptoms, if we find it with respect to respiratory tract, cough, fevers, and malaise, right? 1 to 2 weeks later, about 5% or 3 to 5% of patients develop in specific complications like skin lesions, joint symptoms. So something like that, it usually do it. And the symptoms of a chronic thin wall cavity includes cough, hemophytis, and like it is mostly an asymptomatic. So we are not able to identify it is really an symptomatic or not, right? How we laboratory diagnose it? Is there any specific way to diagnose it or not? Yes, there is a specific test, what we call as a direct examination of sputum. We can go for lung biopsy first also. So again, because it is mostly an acidic condition and it is flourishing very well in acidic conditions, we go for an alkaline KOH or KOH treatment. So that's why we identify it through microscopically using 10% KOH. If we see uh, the morphological characters, I'm sorry, suddenly I got out of the meeting. So if you see with respect to what can be the probable size and shape or morphology colony characteristics of the fungi, usually it is non-budding, thick walled. So usually it varies from 2 to 5 micrometer in diameter, and it contains small endospores as well as granular material, right? So mostly it works with respect to small granules, so granular material, and with respect to small endospores. Okay, this is how it looks like. Totally different compared to what we usually observe with respect to an imitate strain. It is totally different. How it is different is you can see mycoses tissues looks like this. So what we call as in spherix or spherules, just observe this particular portion. So usually the spherules looks not like just like an yeast form. It is totally different with respect to yeast form. So it is just a two-layer structure from outside. So whatever you are seeing, this is what we call as in, so very dark, and within that particular dark form, inside it, it is found over here, right? So from spherules, it has been formed over here, and particular portion like this. Still, whenever it is in gigantic form, the spherules, when it gets accumulated, you always found it in this form, right? And if you want to still observe in under an 40x in a mold form, if it is there in mold form, then how do you found it? You always found it like this. So wherever there is a, you found it in circular fashion, right? In circular fashion, you will able to observe it. Candidiasis immitis strain which is there in the mold form. Now, comparatively, if we see with respect to dermatitis or dermatitis form, it is much more different, right? Now, how much difference is if you just observe it, you can just see the hyphae over here in mold form is much more longer, and just like an hair structure, much more longer and very well established. Even the yeast or in blastodermatitis, you can see it is very circular in form, very large. But if you compare with respect to this particular strain, you will find it coccidioidesis is comparatively not in yeast form also. It is not big. Whenever it big forms and big granules, like it is what we call as a spherules, then and then only we usually observe it in and then giant globose form. Otherwise, always it is observed in a very, very tiny form. And within this particular tiny structure, mostly everything is empty, and that's why we are not able to easily identify it. Further, if we talk with respect to mold form, now in mold form also, we'll be not able to identify compared to blastomyces species. The reason is under a mold form, it happens that it becomes very, very particular globule-like structure. But under a globule-like structure, we are not able to easily screen it out. So that's why it is usually been isolated, or it has been not recognized easily. If we see with respect to colonial appearance in mycelial, just 3 to 5 days of incubation on sebrodextrose agar, STA agar, we can easily found out. It can be easily cultured. It can very exhibit an aerial hyphae, so hyphae will be clearly distinguished. However, there is a specific attachment to the agar. So sometimes we think that just like we remove the spores and we can easily observe on the slide, right? But in order to observe this particular strain, it has possessed an aerial hyphae as well as adherent hyphae, like both, right? So if we talk with respect to aerial hyphae, which will remain on the top, there is an adherent hyphae which will be remain on the particular surface. So we need to observe both. It can't be that we just observe one particular portion and then we stop it. We need to observe both the aerial portion and which is actually bounded with respect to the particular media portion also. So we need to find out both the particular hyphae as well as adherent part. Now, usually if we think how we do it, we usually find it out. It is not easy to observe. We require a specific safe handling of the cultures because we need to remove from the agar surface also. Now, if we want to remove from agar surface, it might happen we lost majority of aerial hyphae during that particular time. So, because we both the hyphae at the same time and observation at the same time, we need to be very careful with the handling of such cultures. Now, what that cultures are called, right? Because it is possessing aerial hyphae, the conidia or the spores are called as an arthroconidia. Now, arthroconidia are the most infectious part and it can travel through air also, right? So usually if we culture it and we stain it in KOH and then observe in microscope, it might happen that during your particular staining or improper handling, the person who is going to observe is automatically infected with such type of conidiospores. So that's why over here, even we usually go for a 10% KOH solution or 10% of particular alkaline solution. It might not work with respect to site of infection or spreading of infection, right? However, with respect to, because we are understanding that all these fungi are dimorphic in nature, there is an yeast phase also. Now, if we want to cultivate the same particular fungi on yeast phase, we need to work with a specific media which we call as a brain heart infusion media. Now, in both the things, the mycelia appearance would be similar, right? There is no much more difference, but over here we need to understand if we are talking about the mycelial phase, majority of the spores or conidiums are in coarse form. If we are talking with respect to yeast phase, majority are there in large or round or septate form, right? So the thing is that hyphae can be easily observed whenever you are talking with respect to mycelia, and yeast phase, it is not true with respect to yeast, it cannot be do it. For serological test, if we are, because it takes near about 4 to 5 days or For mycelial, it takes near about 6 days. If we go for a serological test, there is a specific test which we call as a tube precipitin test. Now, in that, near about 80% of cases which are positives, near about take 2 weeks. But usually, if we do serological test or precipitin test after near about 2 weeks, we will not able to diagnose what is the onset of infection and what is the going to be a source of infection, right? So we'll be not able to identify is it just a true infection with respect to imitative strain or not. With respect to latex agglutination, yes, 93% of cases can be easily detected using immunodiffusion test. And usually in an endemic areas, it can be easily tested. So, however, 6 to 10% false positive results are there in tube precipitin, but with respect to immunodiffusion test, it can be easily done, right? Then just like an bacteriomycin, over here there is an antigen we called as an coccidiodin, right? Over here complement fixation the same as we do with respect to blastomyces species. Over here also we do the similar type of test with respect to coccidiomyces, and the antigen what we recognize over here would be an coccidiodin, right? And this is how it usually works. So titer over here is the same with respect to blastomycosis, but with lower titers like 1 2, 1 4, it can gives us and where if there is an active infection is there or not. And if it is greater than 1 16 or 1 32, again it gives and progress in infection, but poor prognosis is there. Yes, cross infection is there, cross infection not with the blastomyces, but here the cross infection is with respect to histoplasmosis is there, right? And skin test again similar, but the problem is again similar. It is been useful, but again the problem with respect to if we are using a specific antigen derived strain having an ocidioidin in much more higher amount, then and then only it can work very well. Otherwise, the skin test will fail with respect to that particular portion or test. Okay. So with that, we stop our today's session. Mostly what we have understood with respect to specific strain, what we call as a coccidiomyces. So we now understand what is the epidemiology, how can we identify it, is there any serological test, what can be the complement fixation test, immunology test, right? So that's why we work on this particular specific sectors of an coccidioidomycosis, right? So any doubt? I hope everybody was awakened, then and then only I am able to show that. So compared to last next session, I am able to see there is an at least 10 more students who have today joined, irrespective of they are awake or not. But at least good thing is they have joined, and at least some will get a few particular basic understanding. So with that, I'll speak up the name, those who are there, right? And you can just say they are present or not. Okay, everything is clear. Thank you, Ridin. Just a second, I will speak up the particular attendance so that it would be easily done, and then you can leave the meeting, right? Just a second, wait for 1 minute only. It is taking time to load the attendance, that's why. Okay. Okay, so I'll be starting with the naming of the student. Brijesh. You need to unmute yourself and speak up, yes, present or not. Daksh Suthar. Darshak.
Sir, present.
Yes. Darshak.
Present, sir.
Okay. Aniket.
Present.
Aniket is there sleeping. Brijesh.
Present, sir.
Darshan.
Present, sir.
Devi. Devanshi.
Sir, there is
Present,
network
sir.
problem.
Okay. Dhruvi.
Present, sir.
Dhruvi Chandarani.
Present, sir.
Dhruvil.
Present, sir.
Dikshit.
Present, sir.
Diya.
Yes, sir.
Fadili. Fahad.
Yes, sir.
Hanson.
Present, sir.
Hasti.
Present, sir.
Yeah. Hasti Maradia.
Present, sir.
Hetalba.
Present, sir.
Then Hetvi Dawda. Himanshu Domadia.
Present, sir.
Ishika.
Present, sir.
Jaisal. Jaisalba Bhatti.
Present, sir.
Okay. Khushi Parekh. Khushi Parmar.
Present, sir.
Present, sir.
Krishna Maradia. Krishna Vania.
Present, sir.
Mansi Kalaria. Mansi Jotwa.
Present, sir.
Mansi Mani.
Present, sir.
Masti Satani.
Present, sir.
Meet Sanjalia. Dashrak Mob.
Yes, sir.
Nutebi. Nancy.
Yes, sir.
Nandini.
Present, sir.
Nancy. Narendra. Nehal.
Yes, sir.
Yes, sir.
Nelson. Nidhi Vajera. Nidhi Gondalia. Nikita.
Yes, sir.
Okay. Paras Chauhan. Parthachi.
Present, sir.
Priya. Priyanka Dave.
Present, sir.
Priyanka Raj Riddin.
Present, sir.
Present, sir.
Ritika Roni Roshni.
Yes, sir.
Present, sir.
Shak- Shakir Shraddha Shruti.
Present, sir.
Shruti Khokar.
Present, sir.
Shruti Khokar
Present.
Shubham
Present,
Boricha
sir.
Shan Jathwa.
Present, sir.
Present, sir.
Tanya
Present,
Tejas
sir.
Tito.
Yes, sir.
Present, sir. Present.
Umul Vaishnavi Vicky.
Present, sir.
Vijay Vivek Jotania.
Present, sir.
Present, sir.
Yes, sir.
Wilson Esha and Zara.
Present, sir. Present, sir.
Okay. Thank you all.
Present, sir.
Yeah, thank you.